Good morning, everyone. It's my great honor to report our latest result for STEP study. Okay, my title is Intensive Blood Pressure Control in Older Patients with Hypertension, 6-year result of STEP trial. Yeah, we know hypertension imposes a significant burden on cardiovascular disease and mortality rate, both in China and worldwide. With the aging of the population, determination of treatment target for systolic blood pressure in older patients with hypertension has become a challenge and a research focus. Recent 20 years, several RCT studies have investigated the effect of intensive blood pressure lowering on cardiovascular endpoints. However, the optimal blood pressure target remains uncertain. Guideline-based recommendations for the SBP target in older patients remains inconsistent. So we conducted a STEP trial to assess whether intensive treatment would reduce cardiovascular risk to greater extent than standard treatment in Chinese patients with hypertension. Since January 2017, our team started the STEP trial, which was a multi-center randomized controlled trial. We enrolled 8,511 patients enrolled from 42 clinical centers in China. We have assigned two groups. One is the intensive treatment group. The SBP target is 110 to 130. Standard treatment is 130 to 150. So the result STEP was published at New England Medical Journal in 2021. During a follow-up of 3.34 years, intensive treatment brought 26% lower incidence of cardiovascular events than standard treatment. This I have did a presentation in hotline section of ESC 2021. So our recently intensive treatment blood pressure lowering has gradually become an international consensus. Finding of STEP trial has been cited by various guidelines, including 2024 ESC hypertension guideline and recently 2025 AHA ACC hypertension guideline, also including Canadian hypertension guideline, Japanese hypertension guideline, and Australian hypertension guideline. So our STEP trial was previously terminated because of clear cardiovascular benefit observed intensive treatment. To evaluate the long-term effects of intensive treatment and considering ethical principle, so we extended the STEP trial since January 2021. After the original trial ended, during the extended period, all surviving patients, either in the standard group or in the intensive treatment group previous, received intensive treatment in the extended period, referred to as a delayed intensive treatment group or the sustained intensive treatment group. In this period, follow-up visits were scheduled every 6 months. Patients who have participated in original STEP study and are willing to sign the informative consents were included in our extended follow-up. Similar with the previous published study, the primary outcome of extended study was composite of stroke, ACS, and atrial fibrillation, mortality from cardiovascular disease, and all-cause mortality. After excluding patients lost to follow-up, that in original period and those who discontinued intervention or rejected to participate in this extended period, finally, a total of 7,296 patients attended follow-up visit during the extended period, including 3,668 patients in the sustained intensive treatment group and 3,628 in the delayed intensive treatment group. At the baseline of the entire period, the characteristics of patients appear to be well matched between the two groups, including the duration of hypertension for patients. Also, we compared the characteristics of 7,296 patients in the sustained and delayed intensive treatment group during the extended follow-up period. And characteristics were well balanced in these two groups. Patients initiated assigned to the standard treatment group reached the intensive treatment group target during the extended follow-up period. At the final follow-up visit, the mean SPP was 127.9 in the sustained intensive treatment group versus 129.5 in delayed intensive treatment group. Also, we compared the cardiovascular events and safety outcomes between the two groups for the whole course by combining the original trial and the extended follow-up period. The long-term outcome combining the original and the extended period are present in this figure. During the median follow-up period of 6.11 years, primary outcome events occurred in 290 patients, and versus 346 patients in the delayed intensive treatment group. Despite the transition of standard treatment patients to the sustained intensive treatment group, maintained a significant lower risk of primary outcome. HR was 0.82 and the p-value is 0.015. For the second outcomes, the risk of stroke was significantly lower in the sustained intensive treatment group than in the delayed intensive treatment group. HR was 0.72, whereas the risk of coronary revascularization, atrial fibrillation, and death from cardiovascular cause did not differ significantly between the two groups during the long-term follow-up period. Also, in long-term analysis of trial showed no difference in the risk of dialysis, syncope, fracture, and renal outcomes between the two groups. However, hypertension occurred more frequently in the sustained intensive treatment group compared with the delayed intensive treatment group. Also, we want to illustrate the effects of initiation timing of intensive treatment. Hypothetical randomized trial with G formula methods was initiated to compare overall primary outcome risk with intensive treatment initiated for randomization and initiated every year after randomization from 12, 24, 48, 60, and 72 months. Our trial showed an attenuated cardiovascular benefit when initiated at the intensive treatment 12, 24, 6, 36, 42, 48, 60, and 72 months later after randomization, compared with the standard treatment. This intensive treatment initiating from randomization that month yielded the greater benefit with an attenuated cardiovascular benefit for later initiated from 12 months. Furthermore, we employed the group-based trajectory model to identify discrete SBP pattern over 6-year follow-up. Then we use the multi-variable adjusted logistic regression to assess the association between these identified trajectory and composite cardiovascular disease outcome. We can see that our analysis revealed 6 distinct SBP trajectory, which were categorized as low, stable, moderate, rapid decline, and so on. When we compare the risk of cardiovascular events across this group using the low stable group as our reference, we can see a clear risk gradient for cardiovascular events across the trajectory. For patients starting high blood pressure and decreasing their SBP slow inhibit the highest risk represents nearly threshold increase in risk compared to the low stable group. This leads to our central finding. The velocity of SBP reduction is a critical determination of long-term outcomes. Notably, the moderate rapid decline group, characterized by a swift reduction to and maintain SBP below 130 millimeters, exhibited cardiovascular risk that was statistically indistinguishable from the ideal low stable group. This demonstrates that rapid and sustained control can effectively mitigate cardiovascular risk. Furthermore, our subgroup analysis confirmed that slow rate of SBP decline was progressively associated with greater stability risk, irrespective of the patient's baseline SBP level. Thus, our therapeutic goal should not simply to be eventually reach the target SBP. Instead, we must shift our focus to achieve both rapid and stable SBP control. Our study results suggest that sustained intensive blood pressure control could benefit patients with hypertension compared with intensive treatment in the long-term follow-up. Also, the earlier intensive treatment is initiated after hypertension diagnosis, the greater the cardiovascular benefits will be. Our study highlights the importance of promoting intensive treatment initiation for optimal cardiovascular protection. Today, our study was simultaneously published in JCC. So thanks for Helen. And currently, we have a new question. So clinical guideline us with a clear hypertension blood pressure less than 130 and 80 for patients with hypertension. However, this consensus that asks a new and important question: what is the optimal management for individual with an SBP between 130 to 139 or BBP from 80 to 89? Does this population require pharmacological intervention? This remains a critical question in cardiovascular medicine. So to provide the definitive answer to this question and to inform guidelines for hundreds of millions of people worldwide, we launched a new study, means STEP PRE. Our primary goal is to provide a high level RCT evidence on the effectiveness, safety, and pharmacological earlier medication treatment in population with blood pressure from 130 to 139, 80 to 89 millimeters. This is a multi-center randomized prospective study. We have enrolled a large sample of 25,000 participants. These individuals were randomized, assigned into group One is an intervention group and another is a control group, which received health education and pharmacology intervention. In the control group, just receive health education alone. The recruitment period is 1 year, and we anticipate the follow-up period is 3 to 4 years. So today I'm pleased to report that we have successful complete enrollment phase. This is a great effort. We including 160 hospital and research center, and across 30 provinces and in China. We have enrolled 25,000 individuals with pre-hypertension. Crucially, the baseline characteristics between the two groups are well matched, with no significant difference across comprehensive set of variables. So this STEP pre-trial is now in its regular follow-up phase. We have done 1 year follow-up. The project is driven by the dedicated efforts of our team nationwide, where we simultaneously reinforce rigorous quality control. We wish to answer two critical questions. First, does early pharmacology intervention in this pre-hypertension population effectively prevent future major cardiovascular events? And the second is such an intervention cost effective? So, thank you very much.